For those of you that don't know me, I'm Debbie Innes Gomberg. I'm with the Los Angeles County Department of Mental Health, actually a 30-year veteran of the Los Angeles County Department of Mental Health. And in terms of my background, I'm a deputy director over quality outcomes and training. I think why I was asked to do this presentation today is that I've been involved, as have actually several of you, with the Mental Health Services Act since it passed. And I think from 2004 to 2009 in LA County, I was the adult lead. And then from 2009 to 2019, I was the MHSA lead for Los Angeles County. I also had the opportunity to co-chair the MHSA committee with several amazing directors. But here are the learning objectives for today. We'll review a little bit about the Mental Health Services Act. We'll understand the goals and the impact of MHSA, which is pretty significant, as most of you know. We'll understand the history, the laws, and the current policies pertaining to the MHSA. And then we'll understand how changes over time have impact county policy and procedure. All right, so I think in order to understand the impact of MHSA, you have to understand a little bit about the funding limitations that preceded it. And I want to start off in 1988, which is my second year of graduate school, actually. And I want to talk just a moment about AB 3777, the Wright, Bronze, and McCorkadale Act. This was really instrumental, and it actually led to the Mental Health Services Act in many respects. It established a children and adult system of care for those that had serious mental illness or a serious emotional disturbance for kids. And it really, the MHSA really built on this idea of these systems of care and creating a full system of care. The other thing it did, which was really significant and really relates, I think, as a precursor to FSP, is that it authorized 3 pilots in Ventura, Los Angeles, and Stanislaus counties to establish alternatives to state hospitals. And this was actually, if anybody remembers or has heard about the Integrated Service Agency and the Village in Los Angeles being one of them, the AB 3777 provided the opportunity to be able to do that. And this was actually a capitated program where the providers in these 3 counties had financial responsibility for members, including the hospitalization costs. So this really was the success of this program really led to Richard Van Horn, Rusty Seelix, and eventually Darrell Steinberg thinking about AB 34, which we'll get to in a minute, and then the act itself. The second thing which was really important came along in 1991, and that was 1991 realignment, or AB 1288. And for the first time, it really provided a stable funding for the public mental health system through vehicle license fees and sale tax revenue. And this worked out for quite some time, and then at a certain point, it just wasn't the stable funding source that we needed. The other thing it did is it shifted responsibility for mental health services from the state to the county, which really is what realignment is about. And it introduced 3 things: personal service plans, coordinated care, and intensive case management. And so those 3 things were introduced there. So let's talk a little bit about the Mental Health Services Act. One of the primary goals of MHSA was to build on the adult and children's system of care to create a sustained community-based system of care. And community-based is very important in the act. And so that's something just to keep in mind, especially as the act has evolved. And so building on the adult and children's system of care, and so really building on Bronze and McCorkadale. And it built out a model for a comprehensive public mental health system that had, in my opinion, everything you would need. And that is the community services and supports plan. So you have general systems development and FSP, and just a full scope of services for people that already had a mental illness. And then prevention and early intervention. This is something we were never able to do before as mental health plans. And I think Rusty Seelix used to talk about this fail first system that MHSA was really trying to ameliorate. And then it added workforce education and training, capital facilities and technological needs, and innovation. And when you put all those things together, I used to like to think about it as a triangle with infrastructure and then services. It was really, I think, just amazing that they came up with this full comprehensive approach. So the impact of MHSA, it has provided the fiscal and programmatic framework for the specialty mental health system, and I think most of you would agree with that. It's provided transformational change for the public mental health system and really substantial community engagement and voice, including peers and family members. And I know that many of you, if you were in the public mental health system prior to MHSA, we did not have the level of community engagement that MHSA brought us. And I think that that's really important. And then the other thing it did is it really called out transition age youth and older adult as age group service foci. And I think that that's really important. So we had 4 age groups that we were really trying to focus on. I wanted to talk a little bit about the influence of AB 2034. And AB 34 or 2034 really produced the outcomes to demonstrate that small caseload, assertive community treatment like programs are effective in reducing homelessness and incarcerations. And in 1999, AB 34 was launched in LA, Stanislaus, and Sacramento counties and delivered positive outcomes within 6 months. And those of you that were involved in this program know the challenge that took to start a program and then collect the outcomes that suggested it worked all in 6 months. It's really amazing. And that then allowed for the expansion of AB 34 to 2034 and was expanded in over 30 counties. And the architect of MHSA, Daryl Steinberg, Rusty Seelix, Richard Van Horn, all integrally involved in AB 34 and 2034. And FSP was really modeled after AB 2034. 51%, of CSS is FSP, and this really idea of whatever it takes, and the ability to deliver non-Medi-Cal supports, which I'll talk a little bit more about in a moment. But back in 1999, 2000, I remember us calling it hamburger money. And the reason why we did that is because it was about the money that you would need to engage people that were homeless or in the jails, being able to get them a hamburger, coffee, a bed, whatever it takes. So now let's go to 2004 and 2005. Proposition 63 passed on November 2nd, 2004. Those of us that were around then remember that. And it went into effect January 1st of 2005 and became known as the Mental Health Services Act. And as I was putting these slides together, I was like, that was 18 years ago. It's amazing how time has flown in many respects. So what happened after that? The California Department of Mental Health, or DMH, developed MHSA component guidelines. And some of you that were involved in this might have a little bit of PTSD because it was a very intense process. And so they developed component by component these guidelines through information notices and then county templates for the planning process and the submission for approval. And these were phased from 2005 to 2009. And in order to submit a proposal, you had to have a demonstrated significant community program planning process. So these were community-driven plans. And in Los Angeles, it was the most amazing yet challenging thing at the same time, because you had all of these voices, including the county and including many stakeholders that you may or may not have met before, that all were waiting for this moment and all wanted to get everything in the plan. So what happened after that? We developed plans, and then the State Department of Mental Health reviewed and approved plans. And this was a somewhat arduous process. But when they did, then you could start your process. And then our initial reporting was an implementation progress report, which I think was quarterly, and then eventually annual updates, which DMH had to approve to get your next fiscal year funding. And I'll never forget being on the phone with Joseph Kim and other people from state DMH, back and forth on these plans and trying to get it just right so that we can get our funds for next fiscal year. So I just want to talk a little bit about, as counties were developing their CSS plans and implementing full service partnership. Yay, my home county. So Elena, exactly. Congratulations. It was quite a feat. But as we were developing plans and starting to implement FSP, there was an amazing amount of technical support that counties received. The DMH Partnership Conference transitioned to kind of an MHSA CSS series of trainings and meetings. Yeah, and I see Ann Robin, and yes, we did. Karen Hurley was particularly important in that. And I'm sorry, I love the chat and all the memories. And then the other things, the State Department of Mental Health developed the data collection and reporting system, or the DCR, for FSP data reporting. And they gave counties an option to opt out of direct data entry and to use XML data transmission. In Los Angeles, they didn't give us an option. They said you have to use XML. So that took us a while to develop and then the state to approve. But that was the beginning of FSP data entry. And there was trainings on that. Stephanie Oprendeck, I think, was she was at CMH, and then she went to State Department of Mental Health to do those trainings. And then CIMH, which is now CIBHS, provided training and technical assistance on FSP, including the development of FSP toolkits and facilitated FSP networks in each region. And then CMHDA, now CBHDA, initiated the FSP committee. And I have to thank Heather Anders, because as I was creating this slide, I was like, when did the MHSA committee start? And she went back in the archives, and it was somewhere around 2007 that Don Kingdon started the committee, and they didn't really want to even do the committee originally, because I think they thought that the system of care committees would be able to handle it. But I think, as most of us know, as we implemented, there were issues that were just MHSA specific that crossed age groups. And so that started, I think CIBHS supported it initially, and then it became its own CBHDA committee. So let's talk a little bit about 2005 to 2010. The component guidelines were issued through information notices. And it was like when they came out, it was almost like an RFP that you'd respond to, because it was then you had to get to work. So they were issued through information notices, and then regulations were promulgated along the way, with the CSS regulations being promulgated first, somewhere probably around 2009, although I'm not entirely sure. Then the annual update format was the other thing that changed every year. So the information notice would come out that would then indicate the format of your annual update, the forms you had to use, and then of course, they all required approval to obtain next year's fiscal funding by the State Department of Mental Health. And then in 2005, the MHSA non-supplantation guidance was issued. In 2006, we got new service function codes, and those are under Mode 60. And so that introduced non-Medi-Cal supports and non-Medi-Cal capital assets. And so those were the flex funds that were so important, particularly to FSP. And then the next component guideline that was issued was in 2007, and those were the PEI guidelines. And the OAC was in part responsible for those guidelines and for some of the initial meetings that happened with counties around those guidelines. So then in 2008, capital facilities and technological needs guidance where it was issued. Workforce education and training guidance was issued in 2008 as a year. And the other thing that happened was that the WET Regional Partnership Fund availability happened. The MHSA program, housing program was initiated. So a lot of kind of some of the infrastructure. And then in 2009, the mental health loan assumption program, that came to be. In 2009, prudent reserve guidance was given to the counties. And then in that same year, the innovation guidelines were issued through an information notice. And then finally in 2010, PEI statewide projects were initiated through CalMesa, and funds were assigned to CalMesa for statewide projects. So things like Each Mind Matters, and then a number of suicide prevention initiatives, including a backpack, an array of backpacks. I remember on the lawn of the Capitol, each backpack represented somebody who had died by suicide. Some amazing work that happened early on related to the statewide projects. Well, actually, before we do that, I wanted to pause for questions because I think that was a whole lot of years. And so just wanted to check to see if there are any questions before we go on to AB 100. The legislation, so around 2011, we started to see legislation that altered the act in certain ways. And so one of the first legislation that really did that was AB 100. And this was a game changer in many respects. It supported MHSA cash flow to counties and local accountability for MHSA funds. And really the money was realigned to counties so that MHSA plans no longer had to be approved by the State Department of Mental Health. This was really significant because that way you could do your annual update and not have it need to be approved. But stakeholder processes became increasingly important along the way. And then the county mental health plans established performance contracts with DHCS. So this is around the time that that state DMH was going away and the Department of Healthcare Services obtained responsibility for mental health. And then in the following year, AB 1467 was enacted. And this is part of a trailer bill to the fiscal year 12-13 state budget. And it did a number of things. It amended language from the innovation guidelines into the statute. And then county MHSA annual updates and 3-year program and expenditure plans, they said, had to be adopted by the local board of supervisors and then submitted to the OAC within 30 days of that adoption. And this hadn't happened, this didn't happen before. So this then, if you were around in 2012, you all of a sudden were meeting with board offices much more frequently. That's like, what is MHSA? It was really a great opportunity to help the board understand the details of the act and the details of the county's mental health or MHSA plan. And then the other thing it did, it really further defined who our stakeholders should be. And it required counties to demonstrate, and then the other thing is what you want stakeholders to do. So they had to demonstrate a partnership with constituents and stakeholders throughout the process that included meeting stakeholder involvement on mental health policy, program planning and implementation, monitoring, quality improvement, evaluation, and budget allocations. So it really created a lot of transparency between the county departments and the stakeholders. And then providers of alcohol and drug services, excuse me, and healthcare organizations were added to the list of stakeholders to be engaged in these processes. So it really started to expand things out a bit. And then along the way, the Mental Health Services Oversight and Accountability Commission, their role started to expand a bit. And their role in developing the evaluation master plan. Some of you, excuse me, grab some water here. Some of you may remember Joan Mizell, and Joan drafted the master plan for the OAC and met with a lot of stakeholders along the way. And then they had a role, obviously, in approving innovation projects and promulgating the PEI innovation regulations. And some of us remember all those meetings in Sacramento to provide feedback for those regulations. And then kind of more recently, they've been involved in grants, the SB 82 grants, student mental health grants, things along those lines. So their role started to expand a lot as well. So also in 2012, which was 8 years after the act was passed, the legislative people and other folks started to look critically and really started to scrutinize how counties were implementing the act. And, did it really intend, was it achieving the results it was intended to? And so the California State Auditor did an MHSA audit in San Bernardino, Sacramento, Santa Clara, and Los Angeles counties. And the audit results were issued in August 15th of 2013. They also audited the State Department of Mental Health and the OAC. And those of us, and Michelle Smith-Dusick and Josh Morgan in San Bernardino County and a number of others, this was one of those challenging 9-month periods where we couldn't talk to each other about the audit, but we were all involved in the audit deeply. And, it involved just really submitting tons and tons of documentation, and then eventually getting results back. And so the findings were that the OAC provided little oversight. Michelle says that's an understatement. I'll say it was. Yeah. Yeah, it was a little bit PTSD-like. But the OAC provided little oversight of counties' MHSA programs, particularly around effectiveness. And the DMH did not direct counties to evaluate programs. And what you're going to see in the next couple of slides bear this out, is that there was not the infrastructure for evaluation, either at the OAC level or at the State Department of Mental Health level. And that really impacted the ability to tell any sort of story. And then county approaches to assessing and reporting on performance differed. And that actually led eventually to an opportunity for the 4 counties to get together and talk about how they, a common process moving forward. And then they recommended that DHCS establish performance contracts with MHSA that specified program goals and data to measure performance. And so performance contracts were established, although many of you know that they're really kind of around the act itself and the regulations, and a little bit less about data. And then 2 years later, the Little Hoover Commission report, or the Little Hoover Commission did an analysis of MHSA and came out with a report in 2015. And for those of you that don't know, the Little Hoover Commission is really an independent state oversight body that evaluates government operations and policy. And they're a lovely group of people that eventually had an opportunity to meet with several counties, and I think they found it very helpful. But their findings included that effective evaluation had not occurred due to antiquated state technology and overlapping bureaucracies. And the recommendations were to expand the OAC's authority, to improve transparency and financial accountability online, which, when you read these, you realize that's how the OAC dashboards came to be. And then monitor progress towards statewide goals and build infrastructure necessary for evaluation. So then the OAC developed an evaluation committee as a result of this. And before we go on to what I consider the counties fighting back, or banding together and fighting back, I wanted just to check to see if there were any questions about either the Little Hoover Commission report or the MHSA state audit, which were foundational in terms of how we move forward. So what happened as a result of that? And this is a little bit like a story, right? In 2015, or actually probably 2014, several things happened. We realized that the state, well, actually now DHCS, wasn't going to be able to produce FSP outcome reports in any meaningful way, or any other sort of outcome reports. And so we decided to get together and do it ourselves. And basically, I worked with Adrian Shilton, who was at CBHDA at the time, and we developed the methodology for counties to enter data from, and some of you remember this, the enhanced partner, I have to read this, the enhanced partner level data report, EPLDR. And this was a report created by Kate Cordell. And I think the OEC funded Kate to extract data from DHCS on FSP and then be able to create these massive tables that counties then had access to in terms of their own data and could pull information from. Excuse me. And so basically what we did is we then worked with CIBHS to create a data portal and gave counties directions on pull this data, put it in this this field, and then develop and then kind of analyze the results. And then what we did is we had a series of meetings. CBHDA, CIBHS, I believe, was partially involved, the Steinberg Institute, and the OEC was involved. And we reviewed the methodology, we reviewed the data, and then eventually the Steinberg Institute, in conjunction with CBHDA, developed a report in 2015. And it demonstrated the effectiveness of FSP. And then they did a media blitz on this as well. And so what we found is that homelessness was reduced by 47% in adult FSP programs. Emergency mental health and substance use care were reduced. I think that was reduced by 79%, depending on the direction of what we were looking at. Psychiatric hospitalizations reduced by 42%, arrests by 82%, incarcerations by 27%, child out of home placements by 60%. And then there was a 14% increase in clients living independently, a 22% increase in reported academic improvement, and FSP cost offsets. So in other words, all those things that we weren't spending money on in terms of jail and hospital and all that sort of things, those were considered FSP cost offsets. And Angela just put in the chat the MHSA audit link. So that was pretty substantial. And we really, I think, demonstrated that there is, we really are collecting outcomes and reporting on them. And then this should be 2016, but the 2016 Steinberg Institute and CBHD report, we followed it up a year later. And we looked, we did additional analyses for FSP, but then we also added PEI programs and talked about PEI outcome programs PEI programs in various counties and the results that were being achieved. And so here on this slide, you see a variety of different counties, their a PEI program, and then we talked about the results of those programs. Was all data from the DCR? Yes, for FSP programs, all data was from the DCR. And the enhanced partner laid in the EPLDR, that basically extracted data from the DCR and into a kind of a separate database that Kate used to be able to create the report she did. So more recent amendments to the MHSA, AB 114 amended the act related to reversion of MHSA funds. And this was as of July 1st of 2017. And so funds from all the fiscal years from 05-06 through 14-15 were reallocated back to the county of origin for purposes, or for the purposes for which they were originally allocated. So the counties technically reverted funds, but they came right back to them. And then the stipulation around that was that counties must submit a plan to the OAC by July 1st of 2018 to spend those reverted or reallocated funds by July 2020. And then there was a plan, the plan to spend those funds had to be posted on the county's website, with the County Board of Supervisors adopting a final plan to spend funds within 90 days of the posting of that plan. So that was AB 114. And then more recent, again, amendments, AB 2265 and AB 638 amended the act to allow services in CSS PEI and innovation to be broadened to include SUD interventions for clients with co-occurring disorders. And then SB 389 broadened the use of MHSA funds for persons participating in pre or post-sentencing diversion, those on parole, probation, post-release community supervision, or mandatory supervision. And changes to plans must be in the 3-year plan or annual update. And then finally, MHSA fiscal regulations were promulgated on July 1st of 2020.